Chúng ta lại mời lại bác sĩ PG Chang từ Đài Loan, Trung Quốc với cái chủ đề là khuyến cáo áp dụng DEBDOX-TACE trong điều trị HCC. Xin mời bộ phận kỹ thuật.
Good morning again. I hope you are ready for my another experience sharing. The recommendation for the use of DEBDOX-TACE in HCC treatment. These are some of the HCC cases that I treated in my institution. As you can see, these are really large tumors, and I would like you to consider which kind of treatment would you use for these 4 cases: D-TACE, C-TACE, or others. In case A, I choose to use C-TACE, and you can see the lipido retention in the tumor. And for B case, you can see I have done both DEB-TACE and C-TACE. We can see both the tumor necrosis and the lipido retention. For case C, I have done only D-TACE for several times, and we observed tumor necrosis completely. For case D, I have done it with yttrium 90 for the radial embolization. These cases are all stage C HCC. They are more severe cases with abnormally large tumors. In case E, the tumor size is almost 21 centimeters. In case F, you can see the vessel invasion into the inferior vena cava. And for case G, you can see the portal vein tumor thrombosis. And for these cases, what kind of treatment would you choose? DEB-TACE, C-TACE, or others? For case E, I had done palliative TACE for 11 times. And you can see the response are good. For case F, I have done downstaging TACE. So you can see the lipido retention in the tumor and IVC as well, so the patient has another chance to accept operation. For case G, it's the contraindication of TACE because the portal vein tumor thrombosis. So I did it with HAIC, hepatic arterial chemoinfusion, for you can see the partial recanalization of the portal vein. That I have mentioned before, the TACE treatment is done by chemotherapy delivered in high concentrations to enhance coagulative tumor necrosis. And then we added some embolization agents to get arterial obstruction. And that can cause ischemia and resulting in tumor necrosis, thereby reaching a high rate of objective response. Also, we have to be aware that the liver function is important. So we have to preserve the liver function when we carry out TACE treatment. And then this is a comparison table between DEB-TACE and C-TACE. And I have already mentioned that in my previous lectures. So you can see the DEB-TACE, the preparation is consistent and reproducible, and the drug release is sustained. The material of drug-eluting bead is permanent. And then the particle size, we know that it's medium size. And don't forget to put the catheter subsegmental or subsegmental superselection. And the injection rate should be very small. The endpoint should be near stasis. At the end, we all know that the dose of the DEBDOX-TACE we can reach up to 150 milligrams of doxorubicin. Now, I would like to share the DEBDOX-TACE updated technical recommendations. At the bottom of the paper is that I have published in the Liver Cancer Journal that provides recommendations for using DEBDOX-TACE in Asian countries. The Western world had a publication on DEBDOX-TACE technical recommendation as well, but I believe there are differences existing in the treatment and the technical issues between Western and Asian countries. So let's compare the recommendation by Lencioni versus the Taiwan consensus. You can see that for the patient selection, it is quite similar to CTACE, and we can also extend the patient selection in portal vein tumor thrombosis. Perhaps VP1 or VP2, the branch type tumor invasion. We also choose patients to undergo palliative treatment to decrease side effect. For the dose, sometimes we cannot reach near stasis, so we suggested to use unloaded beads or gel foam to treat the extremely hypervascular tumors based on our experiences. For the choice of size, for tumors that are smaller than 3 centimeters, we have the small DEBDOX-TACE, which are similar than 100 micrometers, or even smaller, we call it M1. They are suitable for HCC. Or for AV or AP shunting, don't forget to use some gel foam embolization and do not use it to treat tumors that are smaller than 100 to 300 micrometers. For the injection rate, we should inject it in a slow and steady manner. The rate is determined by the flow within the target vessel. For the endpoint, it's also the same, near stasis, but sometimes when it's not possible to reach near stasis, there will be a non-stasis situation. And when it's happened, we can use unloaded beads or add gel foam or repeat the treatment next time. For post-treatment, it's recommended to follow up the CT or MRI after 4 to 6 weeks. For treatment discontinuations, I believe it's also the same as Lencioni's recommendation. Conduct at least 2 courses of DEBDOX-TACE when tumor cannot be controlled, which is known as deterioration, but for Taiwan consensus, there is no maximum number of embolization if we can treat or control the tumor. Now, let's take a look at the indication and clinical outcome of DEBDOX-TACE in Taiwan. This is the data from Kaohsiung Chang'an Memorial Hospital. They have done DEBDOX-TACE in 240 patients with 1 to multiple tumors. The tumor size ranges from 0.5 to 20.5 centimeter. We can see that they can reach complete necrosis up to 44.2% by using DEBDOX-TACE, and partial response rate is 18.3%. And for the accumulative survival rate, we can see that for stage 1 or 2, they have a higher survival rate in 3-year survival category. For DEBDOX-TACE, stage 3 can achieve a much higher survival rate with 3-year survival, standing at 47%. For BCLC stage, you can see that from stage 0 to stage C, they can achieve a higher survival rate with DEBDOX-TACE than using CTACE. And this is the data from National Cheng Kung University College of Medicine Hospital. And they have the inclusion criteria for patients who did DEBDOX-TACE for the first time. You can see that the cumulative survival rate is almost the same for both CTACE and DEBDOX-TACE. But for cumulative progression-free survival rate, DEBDOX-TACE is longer than CTACE for more than 5 months. So for TACE-naive HCC patients, DTACE shows better efficacy for survival rate. Let me show you the data on drug-eluting beads from my own experiences. I had done 192 times of DEBDOX-TACE on 134 patients. And you can see that the response rate for DEBDOX-TACE can reach up to 53.7 for objective response rate. Then I analyzed the relationship between tumor size and the response rate, and I found out that better results of DEBDOX-TACE treatment are produced for the tumor size between 3 to 8 centimeters in length. For the data we collected, we conclude the same as the recommendation by the DCB eluting beads company that if the lesions are greater than 6 centimeters, then we should choose beads that are between 100 to 300 or 300 to 500 micrometers. If the lesions are smaller or equal to 6 centimeters, then beads that are between 100 and 300 micrometers work best. But I have to say, when in practice, it's more difficult and different from the ideal situations. Reality is usually more complicated. Is DEBDOX-TACE more effective than CTACE? Actually, there are papers that claim that DEBDOX-TACE are much better than CTACE, while there are also papers that claim that DEBDOX-TACE has almost the same effect as CTACE on response rate. So I think, as I had mentioned in my previous lectures, size does matter. So if we can infer that when treating bigger tumors, DEBDOX-TACE might be more effective than CTACE. For some situations, we also use additional embolization materials. For instance, smaller arterial branch or really large tumor and vascular lake formation when we done DEBDOX-TACE. For embolization materials, we can use gel foam, unloaded beads, PVA, or lipiodome. Actually, we had faced vascular lake formation when we used DEBDOX-TACE. In a Japanese paper, the incidence of vascular lake formation in 135 HCC patients is 25.2%. And in my study, it's almost the same. It's 25.8% chance of vascular lake formation. But I analyzed the data and found out that the relationship between the tumor size and the incidence of vascular lake formation. So larger tumors have greater incidence of vascular lake formation. You can see tumor with a mean of 8.3 centimeter have vascular lake formed. This is how I solved the issue of vascular lake formation. If we do not deal with it, or when contrast pooling happens, it can cause delay in intratumoral hemorrhage. So I usually add some gel foam or lipiodome. You can see that when the vascular lake formed and contrast pooling occurred, I added 1 milliliter of lipiodome. So in the follow-up image, you can see that all the tumors necrotized and the vascular lake that filling with lipiodome retention. I believe this is a good way to solve this kind of problem. And sometimes we have small caliber of artery with just one lesion. In this kind of situation, I will also add some lipido. So this is the tumor located in segment 1. And in the following up, you can see the total necrosis of the HCC and some lipido retention. So this is a complete response case. And now I would like to share a few more cases with optimal results. This is a small tumor, smaller than 3 centimeters. So you can see that we use 100 through 300 micrometers DCB. So after the follow-up, you can see this is a complete necrosis, complete response case. But for this small tumor, we can consider to choose small particle or even shift to C-TACE. And this is a case with tumor size between 3 to 8 centimeters. And as you can see, I have chosen 100 to 300 micrometer DCB. This is also a complete necrosis case. For a large tumor case, such as this one, it's up to 10 centimeters, and it's located in segment 4, 5, and 8 of the liver. There is also vascular lake formation observed. After 2 times of DEBDOX-TACE, you can see the necrosis of the tumor and a vascular mass. So this is a partial response case. Here's a very large tumor with size up to 21 centimeters. As you can see, we have done TACE for 11 times. And after the treatment, we arranged to control the tumor quite well. So to treat very large tumor, we have a few options. We can treat TACE treatments if the patient can tolerate the repeated treatments and if we can control the tumors. Sometimes we can consider to combine DEBDOX-TACE with TKI or immunotherapy. For better response rate, we can add extra embolization materials as well. I want to highlight that patients usually can tolerate DEBDOX-TACE better because it has less side effects. Alternatively, you can consider other treatments such as yttrium-90 or hepatic chemo agent infusion. So to conclude the DEBDOX-TACE, the tumor size and the tumor stage are associated with a better response after TACE. And don't forget that accurate patient selections for DEBDOX-TACE or C-TACE can be more beneficial. Sometimes in situations such as small arterial branch or large tumor size or vascular lake formation, we can add some embolism materials. And for TACE indication, for different sizes of tumor. For small size, that is smaller than 3 centimeters, consider to use small size microsphere or C-TACE. For medium size, that is between 3 to 8 centimeters, DEBDOX-TACE is the most suitable choice. For tumors that are larger than 8 centimeters, choose DEBDOX-TACE because it can decrease the side effect. So this is the conclusions of my presentation. Thank you. I hope my case sharing will help you to make better decisions in your practice.